Pooja, could you please check once again?
Yes, I'll check. Yes, we are live.
Thank you for the confirmation, Pooja. Ma'am, we are ready to begin our webinar, ma'am. So, shall we proceed, ma'am?
Yeah, sure, we can.
Thank you, ma'am. A very good evening, a very warm welcome. It's after a long time that Pharm D Community presents a free webinar once again. So this time we are going to start with a totally different branch of medicine, that is pediatrics. So our topic for today is pediatric asthma. Myself, Aishwarya Nair, welcome you all on behalf of the Pharm D community for today's topic, that is pediatric asthma by Dr. Meenakshi C Nayanar. I'm thankful to all the participants from all over the country who have taken out their valuable time and are attending this evening talk. By now, everybody knows what PharmD community is, but still, for the people who have newly joined us, PharmD community has been created with a charter to provide free webinars by doctors and PharmD doctors. We conduct these webinars solely for the purpose of pursuing interest, facilitate, and foster awareness and education in our chosen field of pharmacotherapeutics. Organizing this event would not have been possible with the wholehearted support of my core committee members and the newly joined PharmD community members. So thank you all of you all. I'm also thankful to all the government officials and all our previous speakers who have contributed towards the socio-educational cause and are helping us in spreading medical education for free. It's my pleasure to release the flyer for our next session, which is on next Sunday. And the lecture is a part of our clinical neurology series. We also have an upcoming free webinar on DVT and pulmonary embolism. So that's going to be on 18th of July. The timing is 5 p.m. and the registration link for the same will be posted in the chat box for both YouTube and Zoom. I'm thankful to our speaker for today, Dr. Meenakshi Nayanar, who's one of India's eminent pediatrician. So with this brief introduction, I would like to hand over the session to ma'am. Yeah, over to you, ma'am.
Yeah, thank you, Aishwarya. Thank you for such a lovely introduction. And I thank PharmD community for giving me such a wonderful opportunity. So we are going through such a difficult times now. We are amidst COVID pandemic. So I hope all are healthy. I mean, all are staying home, staying safe. All are good. So I hope we can begin.
Yes, ma'am.
Yeah, I'll just start sharing the screen. Is it visible?
Yes, ma'am. The slides are visible, ma'am.
Okay. So yeah, we are going to talk about asthma, pediatric asthma. It's a vital topic. It's a very vast topic, in fact. So in the next couple of minutes, we'll be going to touch upon the important aspects of asthma, like what causes it, like what is it to have asthma in children, how are they different from adults. So such brief important aspects we'll be touching upon. So to begin with, first we'll be discussing about the definition, like the etiopathogenesis, that is what causes it, epidemiology, the classification of asthma, the clinical features, how we diagnose asthma, how we manage, and what are the important points. I mean, the take-home message. So, to begin with, the definition of asthma. This is a standard textbook definition of asthma. It seems a little complicated, but it only means that it's a chronic inflammatory condition of the lung airways, which results in episodic airflow obstruction. That is, it is something chronic. It is not, asthma is not something that you can have and you can get rid of completely. It's kind of chronic. It is a long-standing condition, and here you have airflow limitation. Your airways are obstructed episodically. There are certain important clinical features that characterize asthma. These are wheeze, shortness of breath. You can have chest tightness, and children can just simply have cough and can manifest with asthma. So if a child comes to you with asthma, which is not responding to the routine medication, simple cough suppressants, we have to keep asthma in our mind. Coming to the etiopathogenesis. So asthma is caused by an interaction of certain environmental factors as well as certain biological factors. So the environmental factors are basically the factors around you. Like it can be an allergen, it could be an infection that has happened to you, it could be a microbe, it could be the air pollution, and it could even be stress. So even prolonged laughter in children can cause asthma. If they laugh for a while, if they play for a while, for a long while, that can cause an acute asthmatic attack. So the biological and genetic factors, you can have certain, by birth, you can be predisposed to have asthma because of certain immune factors within you and certain congenital conditions within you. So what happens is, because of the environmental and the biological interaction, you can have a series of changes that which can happen in your airway and cause certain abnormal repairing changes in your airways that results in asthma. So what basically happens is, this slide explains the pathogenesis of asthma, what happens inside actually. So the antigen there that you see in the picture, that could be anything, the allergen, the environmental factors that we talked just now. It could be a dust, it could be a smoke, a passive tobacco smoke in your home or in your community. It could be the increased air pollution, or it could be the stress, whatever. So that acts as an antigen there. And then that once the antigen enters your body, that is, which is usually through your nose, your respiratory tract, your airway. So once it enters, you have certain antigen presenting cells in your body, which is, for example, it is dendritic cell as shown in the picture. So this presents the antigen to your body's immune cells. So the immune cell that first meets them, the antigen here is T lymphocyte. So the naive T lymphocyte, that is which has not been exposed to this antigen previously. So you can have two types of response there. It could be it is highlighted there as you see. It could be a Th1 response, that is the helper T cell 1 response, or you can have a type 2 response. So the main clinical features and the reason for asthma are mainly the Th2 response mediated. So we'll look into more details of Th2 response now as we are dealing with asthma. So here, what happens is, in the Th2 response, you have a set of mediators that are released. So your helper T cells are now interacting with the antigen, and that results in the release of mast cell, basophils, eosinophils. Eosinophils will be very familiar because we know allergy is very closely linked with rise in eosinophil count. So we have such mediators there, and these in turn release histamine, prostaglandins, leukotrienes, and certain enzymes. So these are the ones that causes your hyper-responsiveness to this allergen. Your bronchial airways basically go into a contraction. It kind of gets constricted, and there is an airway obstruction that happens there. which typically manifest with all the symptoms of asthma, which we just talked, like the wheeze, the chest tightness, the cough that you have, the difficulty in breathing, everything is a result of these bronchial hyperresponsiveness and airway obstruction. So I hope the slide is clear. We'll be going to the next slide. Yeah, so India's coming to the incidence of asthma in India, 6% of the children and 2% of the adults have asthma. And it is a male sex that is slightly more predisposed to asthma than females. Usually, many of you will be aware that females are the ones who are usually predisposed to autoimmune condition. But to asthma, it is a male sex that is more predisposed. Again, the poor living conditions can again predispose you to asthma, like living in a polluted area, very overcrowded area. So such things can actually predispose you to asthma. And if there's any previous history of allergy, any other allergic manifestations, like if you have allergic conjunctivitis, if you have allergic rhinitis, that is allergic running nose or itchy eyes, or if you have skin allergy, if you have simple skin allergy to dust or any such allergens, atopic eczema, which is called. So all these can predispose you to have asthma. And the age-wise, it is usually before 6 years that you first manifest with asthma. So if you have had asthma in childhood, it is likely that you can have it lifelong, or you can completely get rid of it. But like as you see in the slide, the 20% are still are the remaining who have not had any history of asthma in the childhood. So 20% of the individuals who have not had asthma in childhood can still have it for the first time in adulthood. So like typically it is a misconception in the community that like आपको asthma hai, yeah, when we ask have you had such symptoms, no, like for adults especially, they have a difficulty in accepting the diagnosis because they feel as childhood they never had asthma, they never had wheezing. So it is a little difficult to diagnose it in the adulthood, and it is difficult to make them accept the diagnosis. So yeah, like we see the poor living condition here, I would like to highlight one fact. Though this is the incidence of asthma in India, in the past 1 year, we have had very less patients coming to our OPD with asthma. Even the latest journals have reported a significant decline in the incidence of asthma. The main reason being the COVID pandemic. We are all struggling with the pandemic, but there are a few positives that has happened because of the pandemic, one of which is reflected in the incidence of asthma. So the use of N95 mask, personal protective equipments, social distancing, the improved sanitizing techniques that we follow, frequent hand rubs, frequent hand washing, sticking on to hand hygiene very strictly has led to the decline in incidence of asthma as well as respiratory infections. So respiratory infections again predispose you to asthma. So because generally the infection rates of respiratory tract are on the lower side now, asthma have significantly declined in the last 1 year. So one message that we should carry on for our life, a practice that we should carry on for our life is this. So we should probably incorporate these habits in our daily routine to get rid of asthma for life. So so coming to the risk factors for asthma in children. So in which section of children should you suspect asthma, or should you be cautious while talking to them or taking history or seeing them for any other unrelated complaints? So if a child has parental history of asthma, if a child's parents have asthma, if the child has any other allergy, which necessarily need not be asthma, like any skin allergy, atopic eczema, the child has allergic conjunctivitis, rhinitis, if the child has had a past severe lower respiratory tract infection, like severe pneumonia, which has caused us a lot of scarring in your lungs, in the child's lung, so which can be permanent. So in such children, the lung capacity is compromised and they can have asthma. They are liable to have asthma in future. So any history of wheezing, like with colds, there are children who get wheezing along with the simple flu or cold. So they are more likely to have asthma in future. Again, the male gender, like we discussed before. In the low birth weight babies, basically the IUGR, that is children who are intrauterine growth retarded. So they are likely to have an abnormal or aberrant lung development, and they are likely to have asthma in future. So all low birth weight babies should be, kept in mind that they are likely to have asthma in future, especially if they have had past NICU admission, if they have had a difficult course in NICU, if they have had ventilator requirement. Such things can predispose you to asthma in future. Now, another one is environmental tobacco smoke exposure. So there is an increased incidence of asthma reporting in adolescents. So adolescent children, when they go to the habit of certain addictive habits of smoking, they are likely to develop asthma and poor lung functions in future. Even passive smoking, if the child has a parent or a grandparent or a person in their family living in their home who's smoking, can increase the risk of development of asthma in the child. So while smoking, the person should keep it in mind to at least go out of the home or at least stay away and smoke, because that can predispose a child to develop asthma. Again, the last one is reduced lung function at birth, which again could be because of some congenital problems or if the child is preterm. So if a child is born preterm, the child can have ventilator requirement, the child can develop certain illness like bronchiolitis, which can limit your lung capacity. So another example would be cystic fibrosis, bronchiectasis. So these are some of the congenital illnesses that can predispose you to have poor lung function. You can have clogging of secretion in your airways. You can have blocked airways, and you can have poor lung functions at birth, and again, which is carried on to future and predispose the child to develop asthma. Now, coming to classification of asthma, there are there are different types of classification of asthma. We can classify it based on the etiology. We can classify it based on how frequent the symptoms are, how severe it is. And also we can classify it based on the management. So this is the etiology related asthma, that is a transient non-atopic wheezing, or you can have persistent atopy associated asthma. That is mainly what we come across in our clinical practice is the atopy associated asthma. Atopy means allergy basically. So any allergy related asthma. So this is based on management. This is what we follow most commonly. You can have intermittent asthma or you can have persistent asthma. So like the name itself explains, it is self-explanatory. Intermittent is where you have asthma on and off, and in between the child is absolutely fine and stable. Persistent asthma is where you can have it can again be mild, moderate, and severe. So persistent asthma is where you have some amount of symptoms, some amount of limitation throughout. So the limitation could be mild, moderate, severe. That is how it is being classified there. Another one is based on control. So you can have asthma which is well controlled, which is not well controlled, and another one which is very poorly controlled. Again, based on treatment, you can have an easy to treat asthma, a difficult to treat asthma. You can have exacerbations there, and you can have refractory asthma which does not respond to medications. So it is with improved follow plans and with better involvement of the respiratory team, we have we very hardly ever come across refractory asthma. So coming to the clinical features, so to diagnose asthma, we uh, rely upon certain important clinical features. So in children, so we are discussing about the clinical features in children here. So it could be the child could have wheezing, child could have coughing that occurs with exercise, laughing or crying. So this is very typical because we get many mothers who bring their child saying the child has cough and difficulty in breathing after play or after the child has had an outdoor play. Laughing as a trigger is very unrecognized or under-recognized because even though it is after a prolonged laugh that the child develops asthma, it is usually not registered by the mother, so it is usually ignored. So it is important to note that even laughing, prolonged laugh can have difficult followed by a prolonged laugh, child can have limited breathing. So that is one. And another clinical feature would be manifestation of allergic diseases in other forms like eczema, skin allergy, allergic rhinitis, allergic conjunctivitis. There could be itching in the eyes, watery nose, itching in the nose, and such symptoms. Then another important history there is in history of asthma in the first degree relatives, that is parents, sibling. So that way, the first degree relatives, if they have asthma, child is predisposed. Then another way of classifying, diagnosing asthma is based on response to treatment. How well the child responds to your treatment. So if the child shows improvement with controller treatment or reliever treatment, which we'll be discussing in a short while. So that is basically you are using some medicines like bronchodilators, like salbutamol or inhaled steroids. If the child responds well to such treatment, there is a high chance that the child has had asthma. So child can also manifest with poor activity performance, poor exercise performance, and not performing up to the mark compared to their peer group. This which causes emotional frustration in kids again. They can have shortness of breath, they can have difficulty in breathing, and most important is the last point there, which is exclusion of other diagnoses. There are so many other clinical illnesses or diagnoses that mimics asthma. So it is very important to rule out certain other diagnoses. So these are like that includes the cardiac cause. Like there could be difficulty in breathing in the child, and child could actually be having a cardiac illness there. So it is very important to rule out cardiac illness there because there is a separate entity called cardiac asthma. So it is important to rule out any cardiac illnesses or other diagnosis in children. Now, based on wheezing, how frequently children develop wheezing, we can have three types there. So it could be a transient wheezer. It could be the child could be a persistent wheezer. The child could be a late onset wheezer. So basically, transient wheezer is a child who has developed symptoms before the age of 3 and has improved also before the age of 3. So after 3 years, they have nothing. They are absolutely fine. Now, second group is the persistent wheezer who develop symptoms before 3, but that doesn't improve over time. They continue to have it even beyond the age of 6 years. So they are persistent wheezers. Now you can have the last group, that is late onset wheezer, who develop the symptoms after 3 years. They are late to develop. It is after 3 years. So diagnosis of asthma is basically clinical, but we, with the help of certain investigations, we confirm it. So first one is X-ray, where you basically do it to look for any hyperinflation. That is, you can have widely spaced ribs. You can have an hyperinflated chest in the X-ray, and X-ray is an important investigation to rule out other diagnoses, which is very, very important to manage the child. Because if the child with wheezing and with respiratory symptoms, if there are evidence of restrictive lung disease, if there are evidence of bronchiectasis or cystic fibrosis, treatment of the underlying condition will improve the child's symptoms. So X-ray is one investigation, and another important investigation is the lung function test. Now, lung function test is mainly carried out in bigger children and adults. Small children cannot perform the lung function test because it requires a certain level of understanding and cooperation. So small children less than 5-year-old are usually not cooperative to perform lung function test. So basically what we look in there is the forced expiratory volume in 1 second and the peak expiratory flow rate. So basically you have an apparatus like spirometer there. So you'll be asking the child to blow so forcefully. So we'll be measuring the amount of air that is entering the apparatus. That is how it is performed. So from this you would have understood that it requires for the child to have a certain level of understanding. So the problem in pediatric asthma management is many a times child is not cooperative to do that. So that is one. Another test would be allergic sensitization test. So this is mainly for any known allergens, like any food allergen, like the child could be having peanut allergy, child could be having allergy to egg protein, child could have any particular such known allergy already. So such children are at risk of developing asthma and severe bronchospasm, which is fatal when they consume such food. So allergic sensitization tests are basically used to such known allergens. Another investigation is give them a trial of treatment for 2 to 3 months with short-acting beta agonist and a regular low-dose inhaled corticosteroid. So 2 to 3 months of a trial is given with the steroid and the inhaled bronchodilators. If they show improvement, it is very likely that the child has asthma. And if the child does not improve, we have to think of alternative diagnosis. So these are the other diagnoses that should be borne in mind. So a child who comes with repeated wheezing, it could just be a recurrent viral respiratory tract infection. So many a times a child who develops frequent infections and develop wheezing can be misdiagnosed to be having asthma. This is usually cleared over time. The child usually once they reach 7 years, once they have their lymphoid growth maturity, once their lymph nodes and their lymphoid growth is completed, they usually get rid of such infections and they are cured of their symptoms. So that is usually not asthma, it is just recurrent viral respiratory infection. Another one is gastroesophageal reflux disease, which is very common in preterm children. So a preterm child who develops with wheezing very frequently, always look for reflux disease in them. It is usually they are lying supine, they are likely to have reflux. So the refluxed food and milk enter the respiratory airway, cause some irritation there and result in coughing and difficulty in breathing. So that is how it is it closely mimics asthma. Now third one is foreign body aspiration, which is very, very important and should be borne in mind, especially in toddler age group. So each of these diagnoses has a particular age group that we'll suspect. So foreign body aspiration is likely in a toddler age who is ambulant, who's running around, who's playing and exploring. It is very common with peanuts and small marbles. So these are very common. So there could be a small foreign body which has gone unnoticed. The parents probably must not have noticed. The child has inhaled the foreign body in the absence of everyone, and it is sitting there in the airway, not causing much symptom to be fatal, seeking attention immediately, but it is giving a trouble to the child chronically. So when the airway tract is occupied by a foreign body there, it limits the space for the air to enter and it causes typical wheezing sounds there. There could be noisy breathing because of the foreign body that is sitting there. So this should be kept in mind in a toddler child. Next is persistent bacterial bronchitis. This is a close mimic of asthma and it is usually managed with the help of antibiotics. Next is tracheomalacia, which is an it's a congenital condition where you have abnormally dilated and weak airway framework. That is, our airways are made up of certain cartilage rings there. So you have abnormal dilatation of them, which makes them very weak and causes wheezing and difficulty in breathing. Another one is tuberculosis. Tuberculosis is a closed DD which we suspect in poor socioeconomic community. Again, the incidence of tuberculosis is different in each state. In overcrowded places, TB is always kept in mind. CHD, congenital heart disease. Again, like I said, the child can have repeated respiratory infection, repeated difficulty in breathing, but the child could actually be suffering from a heart disease. So, clinical examination is very important to look for any evidence of other evidence of congenital heart disease like bluish discoloration, cyanosis, or any presence of murmur there. Cystic fibrosis is a congenital condition again. So here the child have very clogged and very thick viscous secretions. It remains in the airway, it clogs the airway, and the child has breathing difficulty. And another one is primary ciliary dyskinesia. So cilia, like the name suggests, there is abnormal functions of the cilia. Normal functions of the cilia is important to flush out the secretions normally. So any irritation, any secretion that we have in our airway is usually coughed out. So children with primary ciliary dyskinesia have a bad ciliary function, poor ciliary function. So the secretions remain there, they get infected, and they have poor lung function and have symptoms similar to asthma. And another one is a vascular ring, that is an abnormal ring of vessel that is constricting the airway, which results in wheezing. So that can narrow the airway, bronchoconstriction can result, and similar symptoms can occur. So another one is bronchopulmonary dysplasia. This is typically seen in preterm children. Very preterm or extreme preterm children who are born way ahead of their due date of delivery, something like 28 weeks, something like 26 weeks, 32 weeks. So it is very common in preterm children, especially the very extreme preterm children. So they can have a aberrantly developing lung, and they can have symptoms very similar to asthma. And the last one is immunodeficiency. So congenital immunodeficiency syndromes like SID, severe combined immunodeficiency syndromes, can also have frequent chest infection, very severe pneumonias very frequently, which can closely mimic asthma, and the child can be mistreated as asthma. So like we saw the classification, there is an entity called refractory asthma. So refractory in children with refractory asthma who are not responding to treatment, it is very important to keep in mind, think about the alternative diagnosis and rule them out. It is in many cases, it is not actually asthma. We are missing something there, and we are that is a reason it is not responding to treatment and it is being refractory. So especially in such cases, these differential diagnoses should be kept in mind. Now coming to the treatment. Yeah, the goals of treatment here basically, it is important to control the symptoms, give the child a good activity level. Child should be able to play like his peers, minimize the risk of flare-up or exacerbation, maintain a good lung function, and reduce the side effects of medicine. This is very important because many times parents come to the clinic saying that they are not happy with the medicine. So it is important to minimize the side effects of medicines that you are prescribing. Now we'll be talking about the drugs, the medicine that we use, the classification. So this is the classification of drugs used in asthma. So basically we have bronchodilators, we have anti-inflammatory agents, and we have leukotriene antagonist. So bronchodilators can be beta agonist, muscarinic antagonist, methylxanthines. and anti-inflammatory. So bronchodilators, they help in improving the airway size. So the airflow limitation that is there is improved with these drugs. Now, like we saw in the pathogenesis, we have certain abnormal inflammatory mediators there. So we need something to stop them. So these are the steroids and anti-inflammatory drugs that we commonly use. Now, another classification is the leukotriene antagonist, which inhibit the mediator. Like we saw in the pathogenesis, we saw leukotrienes are one of the important mediators that cause bronchoconstriction. So these are antagonized with the help of leukotriene antagonist. So the previous slides actually, these slides are basically to help us understand each of them act. So like you see in the first part of the image, avoidance is the best thing. Prevention is better than cure, no doubt about it. So in case of known allergens like dust, pollen, cold, or smoke exposure, tobacco smoking, so such things, avoidance is the first thing which should be the rule. So avoidance will totally stop the antigen from being exposed. So that is the first step. Second is the antigen has entered and has interacted with the mast cell there. So that is where omalizumab, which is an anti-IgE drug, that acts. Now the next step is the release of mediators. So the release of mediators is arrested with the help of steroids and hormones there. Now these are the beginning. I mean, once the asthma attack has started, in the initial phase, these will help. Now, once you have crossed that phase, you can leukotrienes and steroids continue to be helpful because steroids have multiple mechanisms of action, which we'll be talking in a while. And leukotriene antagonist will help in late response, that is in inhibiting inflammation there. Again, this is just to show you what is inhibited by each. Ipratropium, like we know, inhibits acetylcholine. Theophylline inhibits adenosine, which is a mediator there. The leukotrienes are inhibited by the leucas, that is the monteleucas, zafirleucas, xylulin, etc. And theophylline is a phosphodiesterase inhibitor and thereby helping in bronchodilation. Yeah, so this is the classification of asthma. So we basically use bronchodilators, leukotriene antagonist, mast cell stabilizers, corticosteroids, and anti-IgE antibody. This is anti-IgE antibody is omalizumab. Steroids are the mainstay of treatment of asthma. The bronchodilators and steroids are most important there. So we'll be looking in more detail about these. Bronchodilators, you have beta sympathomimetics, you have methylxanthines, you have anticholinergics. Corticosteroids can be systemic or inhalation. Again, based on potency, you have low potent, moderate potent, and high potent steroids. Again, this is to explain where each of them act. Like I said, avoiding the antigen or hyposensitizing is the first step that we follow. Once IgE has been released in the early phase, we use omalizumab. At the next phase, to reduce the inflammation as well as to reduce bronchial hyperreactivity, corticosteroids help. That is why steroids are very useful in the management of asthma. They have a wide range of action. Prevention of release mediators is done by mast cell stabilizer. That is, the mediators which causes bronchial hyperresponsiveness and asthma are inhibited by mast cell stabilizers. Now, antagonism of the already released mediators like histamine, leukotriene inhibitors are taken care by the leukotriene antagonist antihistaminic drugs. And we have certain directly acting bronchodilator like methylxanthines. Now, these are the examples of sympathomimetics. The most commonly used ones are salbutamol, terbutaline, the long-acting ones like formoterol. I'm sorry. Yeah, salbutamol is a selective beta-2 agonist. A non-specific sympathomimetic can have a lot of cardiac side effects. So a selective beta-2 agonist have very less cardiac side effects. That is the advantage of using that. So once you use it in the form of inhalation, it starts its action immediately. It is short acting. It usually lasts for around 2 to 4 hours. It is not suitable for a prophylaxis. It is usually to treat the acute attack because it is short-lived, and once the child has already developed symptoms, we advise salbutamol inhalation. Terbutaline is very similar to salbutamol. Again, it is a selective beta agonist. Now, anticholinergic drugs like ipratropium bromide and tiotropium bromide are commonly used. This is especially used in adolescents who have a COPD overlap. In children, it is not used as a first line. First line is always beta agonist. If it is not controlled with beta agonist alone, we add in. It is used as an add-in inhale medication. So it acts by blocking the anticholinergic acetylcholine there. It is an it causes minimized secretion. It reduces the amount of secretions. It dries up the secretion basically. So the side effect is again that you can have dry mouth because of that. Methylxanthine acts by directly relaxing the smooth muscle. You have theophylline and caffeine as an example. Theophylline is very potent. You can have certain cardiac side effects because it causes increased force of contraction in the heart. There can be increased cardiac output. There can be, in high dose, it can result in arrhythmia. So it is not very cardio friendly. In severe cases which are not controlled with beta agonist, the beta-2 agonist or anticholinergics, only in such cases we go in for methylxanthines. It is not used as a first-line drug at all, especially in children. Now, leukotriene antagonist is used as an add-on drug. It is not used as a mainstay of treatment. It is usually an add-on treatment which is used in step 4 or 5 in the management of asthma. It is not used as a step 1 measure. The example there is montelukast and zafirlukast. They help by inhibiting the bronchoconstriction which is caused by leukotriene. As simple as that. The name itself explains that. So it is a very well tolerated drug, especially in children. So children usually tolerate it better than adults. So it is usually given as a add-on treatment or as an add-on treatment in prophylaxis of asthma. Now this is a slide showing various steroids that we use, and the dose is also mentioned there. The examples are budesonide, fluticasone, flunisolide, and cyclisonide. Most commonly used is budesonide and fluticasone. They are very well tolerated and they have very minimal side effects. So fluticasone is a newer drug. It is a high potent steroid and it has longer duration of action. And the dose is usually 100 to 250 microgram twice a day. And depending on the children's age, children's weight, we decide the dose. It can vary from anywhere from 100 to 250. So these are a few new drugs that I would like you to know. These are interleukin-5 receptor blocker, which is benralizumab. Interleukin-5 antagonist is mepolizumab. Interleukin-5 antagonist, another example is reslizumab. So these are not very commonly used in routine practice. The first reason is cost. You can see the cost which is mentioned there at the bottom. So it is usually not affordable, and the trials there have not been enough trials also. So it is not very commonly used in routine clinical practice. But just to know the names, these are the new drugs which basically targets interleukin-5. In the pathogenesis we have seen interleukin-5 is the main culprit which causes the release of mediators. So these are the drugs which target interleukin-5 directly. Now we come to the management of asthma. So now a child comes to you with acute asthmatic attack. So how will you approach the child? How will you basically treat? Now again, in pediatric asthma, we have different approach of management in very young child, in a bigger child, and an adolescent. So first thing when a child comes to our OP is to know whether it is asthma or not. So that is basically by history. We have already discussed the clinical features. So we rule out basically the other potential diagnosis. We once we have narrowed down our diagnosis to asthma, once we have confirmed it is asthma, we first know whether we identify whether it is a mild attack, whether it is moderate, or whether it is severe. So in mild to moderate asthmatic attack, the child will be able to talk, the child will be able to walk, child will be able to tell his symptoms to you. If it is a bigger child will not be very agitated. But if it is a severe asthmatic attack, child will not be able to complete a sentence. Child will be very agitated. Child can have a very fast breathing. The breathing rate will be much more than 30. Again, it depends on the age in pediatrics, because there is a respiratory rate cutoff for a different age group. So if it is a slightly bigger child, I mean to say 6 to 11 years, it will be about 30. The respiratory rate will be definitely more than 30. So the normal rate is somewhere between somewhere around 20. So it should be roughly around 20. If it is much more than 30, it is clearly a severe asthmatic attack. And again, the child can have tachycardia. That is, the pulse rate can be more than 120. And another evidence would be the saturation levels. The oxygen saturation levels, if it is less than 90, the child is definitely having a severe asthmatic attack. If it is something between 90 to 95, it is something mild to moderate. More than 95 is normal. So 90 to 95 is mild to moderate. And if it is a bigger child, we can take the help of a spirometry, a peak flow meter. Peak flow meter is a device which we usually give to the asthmatic children to know their daily performance, how well they are breathing, how well their lung functions. So if the peak expiratory flow rate is more than 50%, the child is not very severely having an asthma. Child is not having a bad asthma there. So if it is less than 50, definitely the child is having a severe asthmatic attack, and we should manage it accordingly. So once we know the severity, if it is mild, moderate, or severe, what we do is transfer accordingly. If it is mild to moderate, we start treatment in the casualty OPD basis itself. But if it is severe, we have to shift the child to an intensive care unit, and accordingly treatment should be directed. So what we do first is we start with the controller medication, the reliever medication. That is, once the child comes with symptoms, for the immediate relief of symptoms, we give certain medicines. So you can see at the bottom there, the reliever medicines are those that are used as needed. That is, when the child has a very severe attack, we use the reliever treatment. Controller treatment is used as a prophylactic method. Like, to prevent attack from coming, we give controller treatment. Now, status asthmaticus is an acute episode of severe bronchospasm, severe enough to cause distress to the patient, not relieved by the conventional bronchodilator therapy. So usually it is managed with the help of, it will need oxygen. It will need the child to be admitted in the intensive care unit in the first place. Child will need oxygen to improve the blood saturation, oxygen saturation levels. Child will need the help of bronchodilators, corticosteroids, and many times such children are dehydrated. So with a very increased respiratory rate, the child has a lot of insensible water loss there. So the child will be dehydrated, and we'll have to rehydrate. We'll have to provide fluids. If the child is very agitated, it is important that you sedate the child well so that the child is calm. Agitation and crying can again worsen the asthma and your lung performance, your respiratory performance. Uh, Another one is if there is a superadded infection. Most of the situations, an acute asthma is triggered by an infection. So the child must have had a viral infection, and the already existing asthma will be worsening. So in such cases, you have to give antibiotics. Now, the asthma medications are broadly classified into three types: the controller medication, reliever medication, and add-on treatments. So controller medications are those that controls symptoms, reduces inflammation, and future risk of exacerbation and related decline in lung function are helped. So these are used just before exercise or when symptoms occur. The examples are low-dose inhaled corticosteroids or formoterol. Now, the reliever medications are those that are used for as-needed relief or of breakthrough symptoms, including worsening of asthma and exacerbation. So, if you have had an acute attack, you will go for reliever medication. You need to get it relieved. So, you use reliever medication. Controller medication, like the name suggests, it is to keep your symptoms under control. It is for a preventive point of view. And then you have add-on therapy, like for severe asthma, like leukotriene antagonist, like we saw the interleukin-5 antagonist, etc. So now this is the stepwise management in treating asthma. Like I said, it is different in different age group. So what we do here is, first step to do is assess whether the child is having asthma or not. First step is to confirm the diagnosis. Second is see if how the symptom control is, if there are any modifiable risk factors, like the child has a parent who is smoking, so the child has passive smoke exposure. So stop that from happening, and the child will have an improved symptom. Treat the associated comorbidity. If the child has associated allergy, skin allergy, the child has respiratory infection, so treat that, and the child will have an improved asthma outcome. Now, the fourth step is check the inhaler technique and adherence. Now, this is very, 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 very important in asthma management, because many a times children who are brought to our OP saying the symptoms are not controlled, it is mostly because of the poor technique and wrong technique or poor adherence. They are usually not compliant with the medicines. So in such cases, it is important that you re-educate them about how to use the medicine, and you show the technique correctly. Give them a diary. Maintaining an asthma diary is very, very important in asthma management, because it is a chronic condition. Regular follow-ups are important to know how frequent the symptoms are, how bad the asthma is in the child. We have to give a asthma diary. So and check the compliance, how well the child is taking. Now, the most important reason for the adolescents having a poorly controlled asthma is poor compliance. Adolescent age group is the age group who are usually non-compliant in pediatric asthma. The children usually are helped by their parents, so it usually goes well controlled up to the age of 11 to 12 years. But from 12 to 15 years, usually they have a bad asthma course, because they are usually non-compliant. They are usually hesitant to take the medication. They do not carry the medication along. They have struggle with the parents fighting for independence, so they are usually not compliant, and adolescents usually have a relapse of asthma during that period. And last one is the patient preference and goals. Whether the child or the parents are okay with the treatment, whether the child is tolerating the drug well, whether there are side effects, whether the child is okay with the inhaler technique. There are children who are age-wise appropriate to use an inhaler, but still demand a spacer. So in such cases, you have to individualize based on your patient's requirement. So these are the first steps to do in the management of asthma. So now, how will you initiate the treatment? So if it depends on the frequency of symptoms. If the symptoms are less than 4 to 5 days a week, if it is less than twice a month, or if it is very less frequent, you will start with step 1. That is, you will introduce a low dose inhaled corticosteroid and a bronchodilator on an on-off basis. That is, when the symptoms appear, you ask the child to take. So that is the first step. Now, if the child has much more frequent symptoms, the child has symptoms like twice a week, the child is having poor school performance, school absenteeism, the child is missing out on his school. So in such cases, you will use a regular controller medication, wherein every day the child takes inhaled medication so that the asthma doesn't happen. And a bad asthma is prevented. So there you use low dose maintenance inhaled corticosteroid and a formoterol, bronchodilator. Now, if the child has even worse symptoms like daily symptoms, the child is waking up from the sleep because of asthma, child is not able to perform like his peers, child is not able to play. So such activity limitation and extremely troubling asthma are managed with high dose corticosteroid, inhaled corticosteroid and a bronchodilator. And at that point, you try introducing add-on therapy, that is step 5, wherein you add leukotriene antagonist or anti-IgE, which is omalizumab, or anti-interleukin 5. So this is the basic funda of managing asthma. So this is how step by step we manage asthma. This is what we discussed already. This is how it is different in adolescents. So again, the inhaler technique is different and the dose is different in adolescents. The funda is what we already discussed, but the dose is different in adolescents, because for children, we usually go for a lower dose of 100 to 250 microgram, whereas in adolescents, we started from 400 to 700, or it can go even up to 1000 microgram in very poorly controlled asthma. This is the important cycle when the child comes for a follow-up. Always we review the child, we assess the child, whether the child has any alternative diagnosis, any suprahepatic chest infection, which has to be taken care of. And next, you adjust the child's routine. The modifiable risk factors are treated. The inhaler technique is checked. The regular the follow-up diary is given, asthma diary is given. So that is the follow-up technique. Now we'll come to the devices. Just for the completion, this is important. Especially in pediatrics, it is important to explain the technique. Now, this is a meter dose inhaler, which will be familiar to most of you. So, how do we use it? These are the parts of the meter dose inhaler. There, you have a chamber there. You have a mouthpiece. And you have the medicines canister with the medicine in that. So what we do is always shake the inhaler well before use. The inhaler will have a free trial without drug in the first few inhalations. It will be marked and it will be written in the pamphlet. So first we shake well before use, breathe out completely, and then keep the mouthpiece, have a close mouth seal. Having a good mouth seal is important so that the air or medicine doesn't escape out. And then having a good coordination while pressing in the canister, you take a breath and hold your breath for 10 seconds. Count for 10 and slowly breathe out. This is a technique, and it is very important to explain to the child with the help of medicines, with the help of images and videos, so that the child understands it well. And during follow-ups, it is important to again demonstrate the technique, because many times the child would have forgotten to hold the breath, or the coordination would be lost, and there can be poor control of symptoms. This is with the chamber, with the spacer or a chamber, which is usually advised in children less than 6 years. So they have poor coordination of breath along with the medicine release. So in such children, we advise spacer, which do not require a good coordination between your breathing in and the release of medicine. So this is very comfortable for children. Again, this needs a demonstration video for the children to be done and to the parents separately. It is important to advise the important measures to be followed while using it. The hygiene has to be advised, like rinsing the mouth after medicine, because inhaled corticosteroids can give the child some local candidiasis otherwise. So it is important to rinse the mouth after use, and washing the spacer. How to sanitize it, how to clean it, how to air dry and sun dry it. Everything has to be explained with the help of information pamphlets. Now, another technique is the dry powder inhalation. These are the inhalers that I use. That is a multi-dose and the discus inhaler, turbo inhaler. This is how it is used. Now, nebulizer is the one that we use commonly for pediatric age group when an acute asthma is precipitated. For acute exacerbation of asthma, we use the help of nebulizer technique. In severely uncontrolled asthmatic children, we advise them to have a nebulizer at home so that they can have the medicines with them. They can have a nebulization at home, have the symptoms relieved, and then before coming to hospital. Because treating asthma in the initial phase is very important, because we have already seen it in the pathogenesis, because all the release of mediators and the extreme symptoms happen towards the end. So with the start of onset of symptoms, with mildest of the symptoms, if you start treatment, it is unlikely that the child will have a severe attack or a severely limited airway. So it is important for the child to have in such children, to advise to have a nebulizer at home and advise and show them how to use it. So this is a nebulizer. You have a chamber there. You can see that green chamber there on the right side of the image. So that is where we instill the medicine. Again, that is dose dependent. In children, it is based on their weight and age that we decide the dose of the bronchodilator and the steroid. And along with some saline, we give the inhalation. Now, there is a wrong practice of giving distilled water for inhalation. Distilled water can actually be counterproductive. It can actually cause bronchoconstriction and can actually, limit your airway performance. It can actually bronchoconstrict. So it is always better to advise saline over distilled water. Yeah, I think that is pretty much it. We have covered the important aspects of asthma. The basic take-home message that I would like to tell you all is that asthma, though it is a chronic condition, it is a kind of lifelong diagnosis. We can control it very well. We can have a normal life. We can give a normal life to the child if it is well controlled. So the importances aspects are early diagnosis, timely treatment, maintaining an asthma diary to know how frequent the symptoms are, and early seeking of medical advice. Early intervention is very important to go on to the later phase and severe bronchoconstriction, because we have already seen if we intervene at the right time, it is unlikely to progress to a severe asthma exacerbation. So, and the lesson that we have learned from this pandemic is that we have to carry on this personal hygiene measures, personal protective equipments, social distancing, hand hygiene, sanitizing ourselves. All these have to be performed lifelong so that we can have a less frequent respiratory infection, less frequent asthma symptoms, and have an easy life. The social distance, the COVID precautions that we had taken have actually reduced a lot of air pollution. We read in the newspaper, Delhi has become much more friendly for the people to live in. The air has got much better purified. These are the few positives that has resulted from the pandemic. Although we are suffering very badly, we have lost a lot of people to the pandemic. It is very bad. It is horrible. There are a lot of negatives. These are a few positives that this pandemic has taught us. I think we should carry these lessons forward. So thank you all. Thank you for your patient listening. I hope it was useful. I wish you all a healthy life. Stay home, stay safe.
Thank you so much, ma'am, for such an informative session, ma'am. You covered everything right from the etiopathogenesis to the differential diagnosis, the clinical signs and symptoms, the clinical presentation, and the various pharmacotherapies that are available for asthma, ma'am. Ma'am, if you permit, ma'am, can we move ahead with the question and answer session?
Yeah, sure, Aishwarya. Thank you. Yeah, sure. We can proceed. Yeah.
Yes, ma'am. Ma'am, you can stop presenting your screen, ma'am.
Oh, yeah.
Ma'am, you have to just click on the stop share option,
Yeah,
which is
yeah.
appearing on the screen.
Yes, I'm clicking on that, but somehow it is not working. Give me a second.
Yeah, sure, ma'am.
That.
Ma'am, can I ask you the first question?
Yeah, sure.
Yeah, our first question is from Zoom, and the participant is asking, how does dermatological conditions cause asthma?
Sorry, could you repeat the question? It was interrupted.
Okay, ma'am. Sorry, ma'am. Sorry for the interruption.
Yeah,
Ma'am, our first question is from Zoom, and the participant is asking, how does dermatological conditions cause asthma?
dermatological condition causing asthma.
Yes, ma'am. Ma'am,
Okay.
is there any link between the two? Like, is there any connection? Like, that's what I guess the person wants to ask.
Yeah, see, it is not exactly, it is not the dermatological condition that can cause asthma. A person who has skin allergy can be predisposed to be having asthma. So basically, when we saw the etiopathogenesis, we have understood that it is all allergen related. I mean, the trigger there is allergen. So that person could be having a skin allergy. So which shows an allergic, sensitivity and increased sensitivity of the person. So such people are more prone to have asthma.
Okay, ma'am. Thank you so much, ma'am. Our next question is, can passive smoking lead to asthma in children? If yes, then what is the duration of exposure?
Okay, see, passive smoke exposure can not only increase the chance of asthma exacerbation, they can have frequent attacks. It can also worsen the lung functions of the child. So duration, the duration is immaterial there. Even a single inhalation of tobacco smoke can cause a lot of bronchoconstriction in the child. A prolonged exposure can result in irreversible changes. So it is important to totally stop. It is not the duration. Duration will harm it further, but it is important to totally stop it. Like if you have a family member who's smoking, it is important that you separate the child from that room, or the person should be doing it or smoking outdoor, at least from his balcony, or as far away from the child as possible.
Ma'am, thank you so much. Our next question is from a registration form, ma'am. The person is asking, corticosteroids can lead to adverse effects like growth failure. How do we manage these adverse events, and what are the specific monitoring parameters that are indicated?
Yeah, that's a good question. Yeah, this corticosteroids, we basically, from the presentation, you would have understood that it is the inhaled corticosteroid that are most frequently used. So the being inhaled, being topical, they have very less systemic side effects. Their systemic side effects are very, very less. It is usually for the systemic corticosteroids that have side effects like growth failure, bone osteopenia, you can have weak bones, all that. So prolonged use of inhaled corticosteroids in a poorly controlled asthma can have some such side effects like growth failure, which is very important in children. So how we monitor it is, again, by using an asthma diary. Like I said, we keep a close watch of the symptoms, how frequent the symptoms are, how frequently the child is using inhaled corticosteroid, how frequent, how the number of puffs are usually increased when the child has an acute attack. So that can give the child a little more dose than usual. So in such cases, the child is likely to have growth failure. So first thing is looking at the asthma diary. So if the child is having a bad asthma, child is likely to have growth failure. So how we monitor growth is with the help of growth charts. So we closely follow the child whenever the child comes to a follow-up clinic. We keep an eye on the height. Height is a good measure to show the chronic, well-being. If the height is affected, that means the child is having a bad asthma control. If the weight is low and the height is normal, it is very likely that the child has had a recent bad course, but the long-standing maintenance was good. So if the child has a very poor height achievement and weight achievement, it shows a poor control. So we follow it with the help of growth charts. We have centiles there. So the child should ideally be above the 50th centile. So if the child is below 50, if the child is falling, if the child was previously, say, around 75th centile, now he has fallen by more than 3 centiles at a stretch. So that means the child is having a growth failure there. So that is how we follow it up.
Thank you so much,
The
ma'am.
usual side effect that we come across is this oral candidiasis with inhaled corticosteroid. So for that, the simple rinsing also helps. So that is why, explaining to them every time they come for follow-up is very important. Some parents and children follow it very well initially, but gradually, once it is well controlled, they tend to relax on that, which shouldn't be encouraged.
Thank you so much, ma'am.
Thank you.
Ma'am, my next question is, why male gender is more prone to asthma apart from occupation working industries like silicosis or allergens? Could you please enlighten us about the same?
Yeah. See, the person has partially answered it already. One is the related to the occupational exposure, like the outdoor work and all that. More than that, the smoking ratio, especially in India, it is more among men than in female. The female smokers are on the lower side. Though it is increasing now, it is still lesser than that compared to the male sex. And another reason is explained by the hormones. Like it is said that the female hormones are slightly, slightly protective. Main reason is main reason is the smoking difference, because men are usually smokers more. The smoking the ratio among men is slightly more than that of females. That is the main reason.
Thank you so much, ma'am. Ma'am, we have some more questions, ma'am. Would you be comfortable in answering them, or are we running out of time?
It's okay. Yeah, you can go ahead.
Ma'am, I couldn't hear you, ma'am.
Yeah, sure. No, I was telling you can ask. No problem.
Okay, ma'am. Thank you so much, ma'am. Another question from our registration form is, which are the best inhalers and can a primary care physician prescribe them, or does it need to be prescribed by a specialist only?
Primary care physician, again, we have talked about pediatric asthma here. So in case of children, it is usually better to be seen by a pediatrician and then start with the inhale technique, because a primary care physician usually, especially in children, cannot be sometimes they may not be capable of completely advising regarding the lung function test. Above 6 years, we can perform lung function test and use of spacers in smaller children. So such things may sometimes be missed. So that can result in a poor, outcome in the child. So it is better that the child is first seen by a pediatrician while initiating the treatment, and the follow-ups can definitely be done by a their family doctor or their primary care physician. They can have a follow-up, and if the child has a bad follow-up report, if the child has had bad control of asthma, and then they can refer. But I feel the first while starting treatment, it is better to be seen by the specialist.
Thank you so much, ma'am. Ma'am, what are the complications for pediatric asthma patients who have contracted COVID-19?
Sorry, it was interrupted. Could you come again?
Yes, ma'am. Ma'am, what are the complications for a pediatric asthmatic patient who has been affected with COVID-19?
Okay. COVID-19 again is it affects children with chronic conditions like that of adults. So children who are having a chronic condition like asthma, they can be slightly more predisposed compared to the other children, compared to the peer group. So they can be more predisposed. And another part of the question was the effects, right?
Yes,
Effects.
ma'am. What is the complications that are seen?
Yeah, so they are slightly more predisposed, and COVID-19 has shown to result in certain irreversible changes in the lung. So that can result in certain fibrosis and certain restriction in the lung function. So that is said to be permanent. So in children, if after COVID-19, such lung fibrosis and decreased lung function can again worsen the outcome of asthma. So they already have a poor lung function that is again attacked by COVID-19 and has increased the fibrosis. So there is a chance that child can have a further deterioration in performance in asthma. Like if he had responded previously better, now he can be slightly badly controlled. So that is possible. The main burden of COVID is on lungs. So that is known to have some certain serious permanent fibrosis, which is bad.
Ma'am, the last question for today's session is there any specific dosage adjustment for pediatric asthmatic patients? How do you calculate the pediatric dose? And how do you calculate the pediatric dose when a child is suffering, when the child is renally or hepatically compromised?
Okay. Yeah. So, like I said, for most of the asthma children, it is the topical inhaled corticosteroids that we give, and inhaled beta stimulants that we give. So, in such children, usually dose adjustments are not needed. If we are giving systemically, if the child has had a bad acute attack of asthma, acute exacerbation, you have to give them injections. If you have to give them systemically, orally or systemically, you have to have some dose adjustments. Again, that depends on the condition. If it is renal, it depends on the GFR, that is the glomerular filtration rate, how much of it is there, if it is how frequently, how bad the renal impairment is. If it is mild renal impairment, it is usually tolerated. But if GFR is very low, if the renal performance is very low, we give it in a modified renal dose, which again it depends on the GFR and the age of the child. That is how we calculate.
Thank you so much, ma'am. With this, we declare our question and answer session over. I would like to thank the speaker for today, Meenakshi ma'am, for taking out her precious time from a busy schedule and delivering such an informative talk. It was indeed a very great web talk with a marvelous presentation. I'm sure all of us have gained immense knowledge through this webinar. This knowledge shall help each and every PharmD or the medical students during their hospital postings. Once again, I would like to thank ma'am. Thank you so much, ma'am.
Yeah, thank you, Aishwarya. Thank PharmD
Also,
community once again.
also, this was a webinar that was actually planned quite long ago, but due to the examinations, it was postponed. Like it was postponed almost 2 to 3 times. So I would like to apologize for that. But
Yeah,
yes, ma'am, thank you so much for
that's
taking our time.
yeah, that's completely understandable. That's okay. Yeah, I too have had a wonderful time.
And we are looking forward for more sessions with you, ma'am. Thank you so much, ma'am.
Yeah, sure. I'm also looking forward to that. Would love to see you again.
Lastly, I would like to thank all the participants who have taken out their time and have attended this evening talk. The registration link for our future webinars, that is, which is on next Sunday, and the webinar on DVD, which is on 18th, has been posted in the chat box for both Zoom and YouTube. And these links would also be posted on our WhatsApp and Telegram groups. So I request all the participants to register themselves for these webinars if they are interested in the following topics. So once again, I would like to thank everybody for attending today's session. Stay tuned, and since the exams are over for most of the students, so we would have at least a webinar in a week. So kindly stay tuned. Ma'am, actually, really sorry to keep you waiting, ma'am. But many people are asking for the presentation. So is it okay if we can upload the presentation on the website so that everybody can
Yeah,
access it?
yeah, that's absolutely fine. Yeah.
Yeah, so I would just like to make an announcement. Pharm D Community has its website. So the web address is www.pharmdcommunity.org. The presentation will be uploaded in this week on the website. So all the students who want the PowerPoint presentation can access the website and can download the previous presentations also. We have posted the presentations. We have uploaded the presentations on our website, and the presentation for asthma would also be uploaded soon. So kindly stay tuned over there. Thank you so much, everybody. Hope to meet you all on next Sunday. Bye.
Yeah. Thank you. Bye.